Good evening, everyone, and hello to anyone who may be watching this on the YouTube channel later. Welcome to the Journal Club. Today, we are lucky to be hosted by the team from Rutgers Robert Wood Medical School. Last year, we actually sent a survey to our subscribers looking for requests and recommendations for faculty and special guests, and there was quite a bit of interest to try and feature Dr. Daniel Feingold, and particularly explore his views on the treatment of anal fissures. Today this becomes a reality, and we're very indebted to both Dr. Feingold and his colleagues for finding the time to host us. So this is our team, valiantly led by Dr. Galandiak. This is our disclaimer. As is my custom, an interesting fact about New Jersey, which importantly has nothing to do with colorectal surgery. And the fact is that paleontologists found the first complete dinosaur skeleton in New Jersey, which is a thing I didn't know. Now, with no further ado, I'd like to introduce Dr. Daniel Feingold. He is the Chief of Colorectal Surgery and the Professor of Surgery at the Rutgers Medical School. And I will kindly ask him to introduce his city, his institution, and his faculty. Thank you.
Hey, thanks very much, Vlad. It's such a pleasure to be here. My faculty and myself, we've enjoyed what you and the rest of the team have been doing with the DC&R Journal Club, and we actually have been anticipating contributing as well. So this worked out nicely. Just to focus on why we're here tonight, as opposed to the pictures of buildings, but this is our home in New Brunswick, the Rutgers Robert Wood Johnson Barnabas Health System and the Cancer Institute of New Jersey. This is a quaternary care hospital with almost 1,000 beds. The real reason I bring up these pictures is because the two buildings that are being built near each of these buildings across the street, that's really what I wanted to get pictures of, but they're still under construction. That's going to add another 100 cancer center beds to our hospital. And so there's a tremendous amount of growth in New Brunswick, and it's very exciting that they're actually spending money rather than saving money. I just wanted to spend a minute introducing some of the faculty. These are many of the names that I think people have heard before, but just putting a picture to the name. This is the Edison faculty up in Edison, New Jersey, where we train 3 fellows a year in colorectal surgery. Of course, Bert Chin, who's here tonight as well. He's the program director, certainly over the last 10 years has been program director for that fellowship. Kirsten Wilkins is here tonight. She's, of course, the treasurer of the American Society of Colorectal Surgery. Suraj Alva and Joe Notaro round out the group. And Ben Karitzkis trained at University of Pennsylvania a few years ago and was just recently recruited by the Edison team to join them. So he's a welcome addition, and he'll be moderating one of the papers today. The other part of the faculty is down here in New Brunswick. This features Kristen Donahue. Kristen trained at Leahy Clinic a few years ago, and we were fortunate enough to recruit her down to join us. Nalmaloni Patel is one of our colorectal surgeons. She spearheads our robotic platform. She's also the program director for general surgery at Rutgers Robert Wood Johnson. Ted Eisenstadt is on the call tonight. Ted is a colorectal surgeon. He was previously up in Edison in that faculty. He was actually my program director in fellowship training 20 years ago. So it's always a pleasure to have Ted with us. Brendan Scully is our newest addition down at New Brunswick. Trained at Columbia University, and we just recruited him to join us a few months ago. I also show here Aliza Rubin. Aliza is our nurse practitioner who specializes in WOCN care and really gives us a comprehensive approach to our colorectal patients. So that's our group. Many of us are here tonight to enjoy the presentations and contribute to the discussion. And again, thanks very much, Vlad, for the invitation.
Thank you. Now, I'm going to use the opportunity of the poll to pick people's brains for a patient that I've actually seen last week. The patient is a young female patient with a synchronous chronic posterior anal fissure, as well as what I think is an intersphincteric or maybe a very low transsphincteric posterior midline fistula. So it'd be great to hear what people would do, and we'll discuss it later in the case. So thank you for that. And whilst people are answering, we'll go to the next slide, please. So this is our first paper, Unroofing Curettage versus Modified Limburg Flap and Pilonidal Disease, a retrospective cohort. This paper comes from Turkey, with Dr. Sahin being the first author. Our hearts, of course, go out to the country with such an enormous death toll following the recent earthquake. So this paper will be presented by Dr. Cass, and then kindly Dr. Koritskis will give us some expert commentary before a short discussion. Thank you. Start when you're ready.
So this paper is unroofing curettage versus modified Limburg flap in pilonidal disease, a retrospective cohort study. Next slide, please. So for background, sacrococcygeal pilonidal disease is a common inflammatory condition, most often seen in young adults. One study estimated it as 25 per 100,000, so relatively common condition. The leading theory, loose hair invagination theory, states that hair accumulation in the natal cleft leads to inflammation and foreign body reaction, causing pilonidal sinus tracts to form, which can then become infected and cause inflammation, irritation, and discomfort for the patient. Many different surgical techniques have been described for SPD, but there's no consensus on the best procedure. Meta-analysis has shown the superiority of off-midline flap techniques as compared with excision and primary closure, but other methods have not been compared. So for this study, it's a retrospective study looking at patients with pilonidal disease undergoing either unroofing and curettage or a modified Limburg flap. So briefly, for the UC or unroofing curettage group, they placed a metal probe through the sinus tract from one opening to another, as shown in the picture here, and simply unroofed the pilonidal disease and curetted it out. Of note, they did not marsupialize the wound edges or excise the wound edges or excise the disease itself. After that, the wound was packed with dry gauze. For the modified Limburg flap group, they did a rhomboid excision of the disease and then a rhomboid flap as shown in the picture and is commonly performed. So transposing the tissue here over to cover the defect and then primarily closing the lateral part of it and placing a drain. So patients in the modified Limburg flap group all had spinal anesthesia, whereas patients in the UC group either had local or spinal anesthesia for patient and anesthesia team preference. In the practice at this hospital, everyone getting spinal anesthesia stayed overnight in the hospital. Post-operatively, patients were seen in the clinic daily in both groups for 3 days post-operatively by the surgeon and staff. In the UC group, the family was taught how to do the dressing changes. In the MLF group, the patients continued to be seen in the clinic for wound care daily until complete healing. So this is very intensive wound care by this team. Follow-up visits were 1 week, 3 months, 6 months, and 12 months, with annual interviews conducted over the phone during the follow-up period, which was approximately 5 years. Patients with acute abscess, abscess drainage within 2 months, uncontrolled diabetes, bleeding disorders, pregnancy, lactation, collagen tissue disorders, or immunosuppression were all excluded. Also of note for this study, each surgery, all of the UC patients were done by one surgeon and all of the MLF patients were done by one other surgeon. So results, the UC group had 135 patients and the MLF group had 143. There were no significant demographic differences. The mean ages were 25.35 and 26.42 in the UC and MLF groups, respectively. More than 85% of the patients were male in both groups. There were no significant difference in the primary outcome, which was recurrence at 5 years. So the UC group had 2 recurrences at 5 years. The MLF group had 6 recurrences at 5 years. Overall, compared to the literature, these are both very low recurrence rates, which I think Dr. Koritskis will mention in his commentary. Surgery was much shorter in the UC group, as you might imagine, 11.4 minutes versus 52 minutes. Length of stay was also shorter, 0.27 days versus 1.07 days. As mentioned, some of that may be driven by the differences in anesthetic technique, because in this practice, a spinal anesthesia required an overnight stay in the hospital. The mean time for return to work or school was significantly shorter in patients in the UC group, 8.6 days plus or minus 8 days versus 25 days plus or minus 6 days. The mean time for complete healing was longer in the UC group, 35 days versus 23 days. The post-op complication rate overall was lower in the UC group. They had 3 complications versus 14. In conclusion, there was no significant difference in the recurrence, which was the primary outcome between these two groups, noting that the recurrence in both groups was very low. Although complete wound healing took longer in the UC patients, overall these patients had less pain, returned to normal activity quicker, and had shorter OR times and length of stay in the hospital. So I think it's reasonable to conclude that unroofing and curettage is a promising technique for treatment of pilonidal disease. The study is limited in that it's a retrospective review of cases, only involving 2 surgeons at 1 institution, and that it may not be generalizable to other practice settings. In particular, their ability to perform intensive wound care themselves is very different to what we're able to do in our setting. And there may also be some patient selection bias. The overall rate of patients who'd ever had an abscess in this group was very low. So these patients maybe did well because they weren't as sick as some of the pilonidal patients would typically see.
Thank you, Willie, for that excellent summary of the paper. I'd like to congratulate the authors on their presentation of this novel surgical technique for the treatment of pilonidal disease, which, as everyone knows, is notoriously difficult to cure. I think, as Willie commented, there's been a lot of excitement around rotational and advancement flaps, and this is supported by the theory that a flap obliterates or elevates the natal or the intergluteal cleft, and also provides a tension-free and off midline closure, and theoretically reduces the risk of recurrence and wound complication after surgery for pilonidal disease, after radical excision. But as the authors rightly point out, these complex techniques are not without their drawbacks, including surgical complications, sure, but also delayed return to normal activity and poor cosmesis. And as in some cases, the surgical cure really may be worse than the disease itself. The reported durability that the authors have found here of their unroofing and curettage technique with a 1.5% recurrence rate at 5 years is really remarkable. And as Willie mentioned, is much lower than reported rates after flap closure or even healing by secondary intention, which are typically an order of magnitude greater, often reported at 10 to even 30% at 5 to 10 years. I think that the authors have also done a great service by incorporating functional outcomes, including the SF-36 quality of life instrument into this study. And they've gotten pretty excellent data at a series of time points over the 5 years of follow-up. These results have certainly forced me to reckon with the very real consequences of flap surgery, including return to daily activities, return to work, return to school, even in patients who don't have a complication. I'd also like to thank them for their review of the published meta-analyses and randomized controlled trials, which is very well done, and I think should really be the nail in the coffin for the technique of excision with primary midline closure, which, as the authors demonstrate here, is significantly inferior to tension-free off midline closure with a flap. In thinking about this paper critically, obviously its limitations, of course, include the retrospective nature of the trial and also the confounding effect of having different surgeons perform the 2 surgical techniques, where one author performed the unroofing and curettage technique and another author performed the flaps. I was also surprised to see that so few patients had had a previous incision and drainage procedure, less than 10% in each arm. At least in my practice, patients don't typically come to our attention until they've had such a procedure, which might suggest a relatively low burden of disease for some of these patients. And for many patients, the described procedure may actually have been their index procedure. It may be a lot to ask a patient to commit to a flap procedure as their very first treatment for pilonidal disease. And lastly, I wonder whether the postoperative wound care regimen, which as it's described was pretty resource intensive, was as much responsible for the favorable outcomes in the unroofing arm as the procedure itself. At the end of the day, again, I commend the authors for their description of a straightforward and effective surgical technique to treat pilonidal disease. And I think that this is a very promising technique to treat index presentations of pilonidal disease, especially in light of its superior functional outcomes. I do worry that we might be getting a little ahead of ourselves in recommending that as the index treatment on the basis of this paper. However, and I do think that the Limburg flap and similar techniques remain essential for complex or recurrent disease. I'll be the first to admit that my own experience is limited, and that in my practice, I'm really just trying to replicate the success of Dr. Bleier and his colleagues at the University of Pennsylvania who trained me. And so I'd like to invite Dr. Chin at this point to comment on his own experience and his preferred technique for the treatment of pilonidal disease.
You know, I thank you, Ben. That's really a nice summary of the paper, and I think two of the techniques that are really favored the flaps and a more conservative excision and curettage. You know, historically, our group has favored an office excision or incision of pilonidal disease. And again, this is not for the acute disease, it's more for chronic and well-established disease. So not for the abscesses and not for acute inflammation. And our experience has actually been similar in that, although it takes many more visits and weeks to heal, the outcome was satisfactory, and the long-term 5-year effects was long-term 5-year recurrence was very low. And one of the benefits of this is that it minimized social factors of having to be out of work and taking time off to get surgery done, and then having a good 1 or 2 weeks downtime after a flap closure and or primary closure of the wound. So our experience historically has been for a limited incision of the wound with curettage with every week or by every 2-week follow-up and cauterization of the wound after curettage. But I think lately there's been some favoritism towards the advancement flaps, and I think it's really the best treatment is a combination of both, finding the right patient and matching it with the right treatment process. So, but I think we have tried different flaps, and I think Ben has showed me some nice results of his Limburg flaps, and he's kind of changed my perspective on that approach, though. So thanks for the opportunity to let me describe our experience with this.
Just have a question. Has any phenol injections that have been reported to be so successful? And I always wonder, do we have to send all our patients to Turkey to get good care? Dr. Wilkins had a comment.
Yeah, I just have a quick question for the group. I've never done the phenol, but one thing that I have toyed around with a little bit lately, and I really haven't been able to find any papers on it, but I've been using some topical Flagyl, 10%, which is more than the standard stuff that you use for rosacea. And I've been having, and I started just using it in some like recalcitrant wounds, like in the anal area in general. And then I started putting it on some pilonidals that weren't healing. And I don't have that many patients, but I have to say it's been like a miracle. So I just didn't know if anybody else has had that experience at all.
To be honest, I haven't used phenol or topical flagell, but you know, in the literature, there are acceptable outcomes with conservative techniques, including depilatory treatments and local wound care. And you know, given the morbidity of some of the flap techniques, I think it's reasonable to start with those.
Dr. Eisenstadt, I think that the take-home message is that with the equivalency results, the initial approach to the majority of patients should be the simpler procedure, a pilonidal cystotomy and curettage. For those that persist or recur, then a more extensive flap procedure would be considered. That was always my approach. The low recurrence rate with the simpler procedure, except in cases where you may have a very prominent coccyx, very little subcutaneous tissue that might initiate a flap procedure first.
Thank you. Dr. Walters, I think, has his hand up as well.
Yes, I'm an alumnus of the Eisenstadt Rubin Salvati program from many years ago. I was the program director and senior partner in our fellowship group in Hartford, Connecticut, but I'm now retired. And just a couple of points. Dr. Salvati always referred to pilonidal disease as a 5-cent disease with a lot of 50-cent solutions. I would point out that the flap contingent of this study had significantly greater intensity of wound care, whereas the unroofing and curettage group was sent home to their families, and yet the unroofing and curettage group still had superior outcomes. And so it would, just going on with Ted's comment, that it would seem that approach, with its earlier return to activities, with its really earlier recovery on everything except complete wound closure, really is sort of a superior initial approach. It seems in my own mind, and that was our approach in when I was in practice, retired now.
Thank you for that. I noticed that there's a interesting comment from Dr. Mackerel in the chat about endoscopic treatment of pilonidal sinus tracts. Are you able to, can we unmute you? Are you able to just share that experience with us?
Sure. Hi, Dave McCrill here from Mackay in Queensland. I've seen a lot of flaps, a lot of resections in terms of registrars and fellows, and always hated the problems when people had recurrences and wound failure and just incessant vac dressings and all the rest. So once I became a consultant, I tried to minimise those that I did, and looking through the previous data and stuff in CSSA and Z, there's a lot of good stuff about using phenol. And if you can get the pure crystal phenol, fantastic. But kind of oily phenol, like you have for hemoral injections, is also readily available. And yeah, so I've had patients with small volume symptomatic pilonidal sinus disease. I'd have them in theatre, excise the main kind of draining pits and any kind of midline pits, do a full kind of curettage and debridement, and then put oily fill into the cavity and then a dressing over the top. And I'd keep the wound covered for at least 3 weeks till everything's all healed. Patient managing these things at home, and had very good results with the use of debridement and phenol. And if any time there was a situation where it was a higher volume disease, then yeah, use the EPSIT procedure, and afterwards using a portable negative pressure dressing over the most kind of crenal aspect of the wound. And these patients are all in and out of hospital the same day. Often they can get back to work and their school and education very quickly. And I think it's always worthwhile trying something minimalistic like this, because you never lose anything. You're never going to make a flap more difficult or more involved surgery, more challenging by trying something simple first.
Thank you. Great point. I usually read with interest Dr. Gottsman's articles in the DC&R with quite a bit of flair in even just the names themselves. And if it's possible, maybe he can add some flair to this fairly unflareable disease, for want of a better name.
Thank you. So my approach to all disease, be it acute or chronic, is to excise the pit and open up the fistula tracts. It's done either in my office or in the hospital under MAC anesthesia. I think what I do differently is I do not pack the wound, and I have patients use a high pressure water jet to clean the wound twice a day, and that debrides the wound very well. And I see them every 2 weeks, and no matter how big the wound is, they heal beautifully. Recurrence rates are minimal. And I think that's the best of both worlds, because you're not, my attitude is, if you're going to do an operation, do it once and get it right, not do a little operation, and if it comes back, do a bigger operation. So I tell them they're going to have a big wound, but the downtime is minimal. And if they take care of the wound, there's no packing, there's no wound care at all. Just keep it covered, and they heal beautifully with very minimal downtime.
Thank you.
Sure.
I've got one last question for the panel. I've recently saw a young female patient with quite a muscular sort of gluteal region with quite a pronounced curve. So she has a large secondary tract with an opening, but no obvious midline pits. I've excluded an anal fistula. And my question is, do people subscribe to the congenital pilonidal cyst theory? And what do you generally do if you have a patient with no obvious midline pit? Do you still excise the whole thing, or do you just focus on the lateral extension?
I would be very uncomfortable to inflict a wound on the midline if there's really no midline pits. And so it raises the question if this is what I would describe more as a boil than a pilonidal process. So I would focus on the exact area. I would excise that area, debride it to healthy tissue, and generally I leave that open to close on its own over time. You see this from time to time, especially in the buttocks, and I think that this might very well be just a primary boil as opposed to a sinus tracking from the midline. Any other thoughts? Anybody else would manage that differently?
No, I mean, I agree with you, Danny. I would probably not go to the midline, and I'd be more concerned, is like you said, is this just a boil or hidradenitis, and just take care of the stuff lateral first and see what happens.
I would just suggest that if you open up the area of concern and then follow the granulation tissue, and if it goes to the midline, just excise everything into the midline. I don't think the midline is as sacrosanct as everybody makes it out to be. And then just follow the granulation tissue. If it goes to the midline, it could have been a pilonidal sinus. To answer the other question, I do not buy the acquired disease theory. I think it's congenital. I see too many women with not a drop of hair on their bottom with pilonidal cysts, and I just wonder where that comes from. So I do subscribe to the congenital theory.
Thank you. Who would have thought that pilonidal disease brings so much passion out in the colorectal community? Now, I think in the interest of time, let's move on to the next case, please.
As we're doing that, that was Willie Cass who presented the first paper. Willie's one of the current fellows in the Edison Fellowship for Colorectal Surgery. And moving forward, we have Alex Rossi is going to present the next paper. Alex is one of the fourth-year general surgery residents here at Rutgers University, and he has the pleasure of applying to fellowship next year. So you might be seeing his name as he comes about. So with that in mind, we can go ahead with the next paper, Dr. Rossi. And this will be moderated by Kristen Donahue.
Thank you very much.
Fantastic.
Good evening, everyone. So I'm going to be talking about botulinum toxin injection plus topical diltiazem for chronic anal fissure, a randomized double-blind clinical trial and long-term outcome. This paper was coming to us from Valencia, Spain, and took place over the last 20 or so years. By way of background, chemical sphincterotomy with botulinum toxin has emerged as a lower incontinence risk and less invasive management option of chronic anal fissures, with 80% reported healing rates from botulinum toxin injection, which has been reported as superior to topical nitrates and calcium channel blockers, where their healing rates range between 46 and 58% in the literature. Recurrence rates with either of these therapies are similar, around 40 to 60%. This compares to the gold standard of the lateral internal sphincterotomy, which healing rates surpassing 95%, extremely low recurrence rates, and about a 10% long-term incontinence risk. A pioneer study that led way for this study to be done, combining botulinum toxin with diltiazem cream, displayed promising results. And the authors of this study sought to more rigorously interrogate this approach and report on long-term functional and clinical outcomes, which was something that was lacking in that pioneer study. Next slide, please. So methods. This was a single institution randomized controlled double-blinded clinical trial. The two arms were Botox injection of 20 units, 10 on either side, along in combination with diltiazem gel versus just the Botox injection alone and a placebo gel. The study was powered to detect a 20% difference in treatment effect, and added 5 patients accounting for attrition. So each arm had 35 patients. They also did both an intention to treat analysis that included the loss to follow-up patients as failures and a per protocol analysis separately, which categorized loss to follow-up as exclusions, which was relatively impactful, and we'll get to that. There was a 1-to-1 allocation of serial patients presenting with chronic anal fissures to their clinic. The inclusion criteria were very stringent. The patients had to have a symptomatic posterior midline chronic anal fissure on examination with significant pain, defined as a greater than 3 out of 10 on the visual analog scale, at least 5 times per week, and this for lasting at least 8 weeks, to be categorized as a chronic fissure. And these were allowed to have been treated with conservative measures or topicals prior. Exclusionary criteria: any comorbidities such as AIDS, IBD, STIs, TB, leukemia, any history of anal surgery, lateral or anterior locations, asymptomatic or minimally symptomatic fissures, and the inability to receive Botox or a calcium channel blocker cream. And these patients were followed clinically via symptom diary, a physical exam, and manometry. Next slide, please. The randomization between these two groups was adequate. There were no significant differences on any of the clinical, pathologic, or demographic categories, and you can see that in table 1 there in the center of the slide. The overall healing rates were remarkably poor. In the per protocol analysis, there was 52% healing rate in the diltiazem arm and 36.7% in the placebo arm at 12 weeks. And the recurrence rates were very high, with 62% at 24 months and 80% by 10 years, with no significant difference between arms. These recurrence rates are influenced by a very small sample size, however, as the loss to follow-up, and there was significant attrition over time with of the 70 patients initially enrolled in this study, only 24 made it to the endpoint at 10 years. They also did a sub-analysis of characteristics of those that recurred versus those that did not, and there was no significant difference between the two groups, with the exception that the presence of an anal tag was more likely to portend a recurrence than not a recurrence. And then on the far right of the slide, you'll see a flowed consort diagram of the reevaluations where the patients underwent a repeat exam each time, the number that were found to be healing versus the number that were lost to attrition. Overall, there were no significant differences noted between the two treatment arms. Overall healing rates were extremely low compared to previously reported series on botulinum toxin injection. And this may be attributable to a number of factors. The selection criteria for only symptomatic chronic fistulas, fissures, excuse me, that's a typo, were extremely stringent, and by excluding the acute fissures, which have classically higher healing rates, you're significantly influencing your ability to encounter healing patients. There was also very stringent morphologic criteria utilized for evaluation, and the repeat examinations were done regardless of symptoms. So in the case of an asymptomatic patient that would clinically be considered healed, in this study, these patients were reevaluated and were only considered healed if they met clinical pathologic criteria and were evaluated for the presence of a scar or granulation tissue, etc. There were very few adverse reactions identified in either arm, although transient minor incontinence was identified in 30% of the cases overall. There are also extremely high published recurrence rates in this study. However, given the small sample size, those rates are obviously influenced by the lack of depth to the population. And the ability to detect patient factors that increase the risk of recurrent disease was limited also by the same sample size. Question?
Thank you very much for that. If I can please have Dr. Donahue give us some expert comments. Thank you.
Sure. I wanted to thank Alex for that presentation. That was very thorough. I think that anal fissures are something that plague all of us in our practice. The one thing I thought was interesting in this paper, I think statistically it makes sense for them to say that the patients that are lost to follow-up are counted as failures, but I would say in my practice, the patients that are failing are not lost to follow-up, and those are the ones that you continue to hear from who are still symptomatic and coming back to you. So I think that that may skew the results in this paper slightly, just in saying that, you know, those patients aren't healed because they're not coming back for follow-up. Obviously, that's a limitation of having such stringent and long-term follow-up. I do think the strengths of the paper include the randomized clinical trial, the fact that there was such long follow-up over 10 years, and that they had an objective clinical exam, though Alex's comments are well taken that, you know, in patients who would otherwise be asymptomatic and feel healed, we're now, you know, labeling them as failures just based on clinical exam as well. I did have sort of a question for the group. When we were discussing this amongst our faculty, the number of units used, only 20 seemed low in our practice. So I sort of wanted to open that up to the group and see what others are doing and have been doing to treat with Botox.
Yeah, I mean, I agree that 20 units seems very low. You know, typically the Botox comes available as 100 units, and I'll typically use about 80. And the reason I choose that is that, you know, when the nurses, the way I reconstituted just 1 ml of saline. And many times, you know, when you actually are given the actual Botox, it's like 0.8 mLs by the time you get it. And then I deliver it in all 4 quadrants, 20, 20, 20, 20. I just like that technique. I think one of the reasons why, you know, this paper maybe had such, you know, low success, I really do think a big part of doing surgery for the fissure with the Botox is actually debriding and giving a fresh healing base to the to the fissure bed itself. You get rid of that sentinel tag, you give a fresh base, and they didn't do that from what I can tell in this paper. It was just injecting the Botox. So not surprising that the patients that had the tags had the less chance of cure, because those are the patients that you should really probably be debriding. So that's my.
So Kirsten, if you're going to do it that way, do you do all your Botox injections under sedation?
Yes, I do, because I always debride it and biopsy. I like to biopsy it as well. I mean, most of the time it's nothing abnormal, but occasionally a non-healing wound can be, unexpected cancer or something like that. That's rare, but I do think it should be biopsied. And the other thing is, we've looked at our own series, and I would say 10 to 15% of people will get a fissure fistula, right? So when you take patients to surgery for the Botox, a lot of times you may find that you didn't see it like when you saw them in the office or whatever. When you get them asleep, you can see it easily. So they'll have a superficial intrasphincteric fistula that you can easily cure them by doing just a fistulotomy there. I think that kind of relates to the original question that we were presented at the beginning, but it's not uncommon that you'll see that. So yeah, I do them all in surgery.
Thank you very much. I think Dr. Grossman has his hand up.
Yeah, thank you. So I think there's a few issues. One is the diffusion of Botox is not that much. It goes per injection about 50 millimeters of diffusion. So I think it's important to inject more volume with a higher dose. So I do 100, but I do it in 4 1 cc injections, because I want the Botox to diffuse more than a small volume injection. So that's my technique. The other thing about the diltiazem, I use it in the second month of Botox, so that when the Botox is wearing off, they have protection with diltiazem. I think giving them concurrently makes 0 sense from a physiologic point of view.
Thank you. Dr. Eisenstadt, I'm sorry, is it Eisenstadt? I'm sorry.
That's okay. Dr. Eisenstadt, thank you. I think an important point to be made is that with conservative management, the initial presentation of anal fissure, 50% of the patients will heal and don't need further treatment. We reserve Botox and other modalities for the patients who are persistent and require further treatment. An important point to be made also is that lateral internal sphincterotomy is a very safe operation. Part of the problems with the reports on lateral internal sphincterotomy are that frequently patients are not followed long enough, so that we've looked at a number of different studies. One of our studies was 500 patients followed for 10 for an average of 6 years, with a non-healing rate of only 1%, a recurrence rate of about 11 to 15%, incontinence rate of 8%. But early on, a lot of these patients after sphincterotomy are incontinent slightly. It does usually get better. And the longer you follow these patients, I think you will find a higher recurrence rate, but which can be handled with a flap procedure or another sphincterotomy.
Thank you. I at the moment use the lateral sphincterotomy quite a bit, primarily because in the hospital sector, in the public hospital sector in Australia, there's a huge waiting list after COVID. And I find that for the patients to wait to have their Botox injected, which is not an urgent procedure, and for the patients that have recurrent disease to then wait again, they're sometimes waiting for 1.5 years to get their fissure treated, which is obviously horrendous. And so I cut out the middleman, excuse the pun, and just go through to the lateral internal sphincterotomy. And clinically and symptomatically, it seems to work. I'm not old enough to see what's going to happen to them in 20 years' time. I hope they don't all sue me, but it seems to relieve a lot more symptoms. But that's probably the effect of public health, more so than the pathology. a question I have for the team is, in the study, there was a comment about the reduction in the squeeze pressure on anal manometry. Is that at all relevant? Because we're talking about the external sphincter versus the internal sphincter. Is that a side effect of Botox? Is it potentially the fact that we're using large anal retractors that kind of act like a, you know, an element of the Lord's procedure, and maybe that's why people get healing of the fissures more so than the injections? So some comments about the effect on the external sphincter, please.
I would just say in the few patients that have had transient minor incontinence, I always wonder if it's more a factor of, you know, did I let the resident inject on one side and did they actually inject into the external sphincter, not the internal sphincter? But obviously in a randomized control trial, I'm hopeful that these were more directed injections. But you're right. I mean, we shouldn't obviously see changes in manometry, but also how clinically relevant is manometry in this disease process? And I'm not sure the answer to that.
I thought it was
very much for that.
Interesting, Vlad, how they included manometric data, but I don't think there's much clinical utility in terms of a metric with manometry, especially in the setting of a highly symptomatic anal fissure. But they collected the data, and here now we get a chance to talk about it.
Fair point. Thank you, everyone, for this. Now we're going to move on to the results of our poll. Stephen, if you can let everyone know what that is, please.
Yeah, so the poll results should be up. So this is for a fairly complicated young female patient with a posterior midline fissure and a posterior midline intersphincteric fistulated ano, or low transsphincteric. So there's a variety of kind of two option answers here. So the first, a fistulotomy versus a cutting ceton got the most votes. Second to that was a ceton and Botox / lateral sphincterotomy. So addressing the tone more at the offset. And then you could see as it kind of goes down, lateral internal sphincterotomy with a mucosal advancement flap or lift in the acute setting, and even lower that for the other option of a Botox with a lift or advancement flap.
Thank you very much for that. I guess I've got a few questions for the faculty, and perhaps you guys will share what you would do with such a patient. My concern with the fistulotomy is I'm worried that I will create a keyhole deformity and therefore a chronic seepage. I think that's my biggest concern. But yeah, I'd be interested to see what the faculty will do, please.
I mean, I personally haven't had a problem with seepage when you're doing the superficial. It's typically a very superficial fistula. It's almost always a subcutaneous or very, very superficial intersphincteric fistula. It's rare to have like a deep transsphincteric. If it was deep transsphincteric, I wouldn't do a fistulotomy, but I would say 99% of the times, these are very, very superficial fistulae, and I haven't had a problem with that. The other option for doing the ceton and the partial lateral internal sphincterotomy, I'd be careful about that because these people do have like a little localized sepsis. And I always tell the residents, the first thing you want to do is check to make sure you don't have that fissure fistula. Because if you have that fissure fistula and you're cutting some muscle there and you add a little bit of Botox in, it's unlikely you would ever need a partial lateral internal sphincterotomy. So you certainly don't want to do your sphincterotomy first laterally and then have to come back and do a fistulotomy another time. Then you're cutting too much muscle. So that's my opinion.
Thank you. Great. Anyone else? Dr. Eisenstadt, is your hand up from the previous discussion or from now?
Yeah, my hand was still raised from the other comment. However, you are dealing with an infection here. You have an abscess, and I think that has to be addressed. And I would agree with Kirsten that it is usually a very superficial intersphincteric posterior fistula, and seepage is not as much of a concern, but I wouldn't do a sphincterotomy a lateral sphincterotomy in face of an infection.
Thank you for that. Now, let's move on to our last component of Journal Club, which is our special guest feature. And we're very fortunate to have Dr. Feingold today. Just a few comments about him. So he completed his residency in the Barnes Jewish Hospital in Washington University, and as well as New York Presbyterian Hospital at Columbia. Dr. Feingold then undertook dual fellowship in both surgical oncology and colorectal surgery back in 2004. He was an attending at Columbia University for 15 years prior to his current appointment at the Robert Wood Johnson University Hospital as Chief of Colorectal Surgery and Professor of Surgery at the Rutgers Medical School. And specifically today, I was hoping to talk to him about the Kenalog procedure that he has developed for fissures in ano. So my first question, which is somewhat obvious, what is the Kenalog procedure, and what are the technical steps of it?
So what I affectionately call the Kenalog procedure is an outpatient procedure done under general anesthesia. Usually it's an LMA. I specifically avoid conscious sedation. I feel that the deep sedation of an LMA, or for that matter, an endotracheal tube, helps relax the pelvic floor. And so I don't perform the procedure under anything short of general. There's four main components, as I explained to patients, of what we'll be doing. The first is clearly a component of degree of dilation. We're sequentially dilating the anus with Hill-Ferguson retractors. And then I insert a Fansler anoscope. My Fanslers are 4.3 centimeters in diameter. The majority of the patients have a hypertonic sphincter, and so there's clearly a component or a degree of mechanical dilation. Next is sharp curettage. I use curettes to literally curette out the base of the fissure. Next, I cauterize the wounds. That's the third component with electrocautery. And then the fourth component is injecting the triamcinolone. This is an injection with a 22 gauge needle right into the base of the fissure. This is internal sphincter muscle. I inject 50 milligrams of Kenalog in 5 cc's. I was very happy to hear the comments, Dr. Wilkins and others, about the relatively common finding of some kind of fistula. I would argue that the vast majority of patients that I actually wind up taking for this procedure have some degree of, it's technically a sinus, meaning there's no two openings vis-a-vis a fistula for the majority of these patients, but there's very commonly a sinus of a burrowing inflammation underneath the skin at the outside component of the fissure. And unroofing that, which is sinusotomy, I find is very helpful. It allows me to access the fissure better. It does create somewhat of a larger wound than what you started with, but I found early on that if you don't address that area of burrowing, there's a festering inflammation and the wounds don't heal as well. So those are the components of the Kenalog procedure.
Thank you very much. The second question is, how was this procedure born? What's the backstory?
So my residents and fellows know the story because they ask me all the time. So if you go back to 2008, I was on staff at Columbia, and my typical patient had already seen at least 2, if not 3 other colorectal surgeons on the island of Manhattan. And the simple story is that I had 3, independently, 3 women came to see me with recalcitrant fissures over a short period of time, and they each had seen some very prominent surgeons on the island, and they essentially told me at the time, young man, don't talk to me about sphincterotomy. They were interested in some other solution. They had failed Botox, and they were not interested in sphincterotomy, which had been offered repeatedly. All 3 were elderly patients. They were all women. One had had radiation therapy for a previous malignancy. So I did not offer sphincterotomy, and I sat down to figure out how I might be able to help them heal their wounds. And it occurred to me to treat their fissures as exactly what they are, which is a chronic wound. And so how do we treat chronic wounds? We debride them and we cauterize them. I felt that there was something missing. And before I treated the three, I spoke to Dr. Eugene Salvati, who was my mentor in fellowship. And I asked Dr. Salvati what he would do. And he answered without any hesitation that he would inject Kenalog. And I didn't know what Kenalog was. And I wasn't sure that it actually had ever been injected into the anus before. I couldn't find any literature about intraanal Kenalog injection. I looked into it, and of course, Kenalog triamcinolone had been injected for over 100 years in intra-articular for treatment of arthritis and into keloid scars, essentially everywhere from the clavicle down, I was able to find other than intraanal. Anyway, I put together this idea of an exam under anesthesia with the instruments that we typically use in terms of anoscopes, together with the other three components of the procedure. And the three women healed. I wasn't sure what would happen, but all three healed. And so I did 10 patients, and then 30, and then 100, and now just over 450 patients. So that's how it came to be.
Fantastic. And can you please tell me, what is your patient selection now? Do you do it on everyone, or do you do it on people who are not amenable to sort of the more traditional approaches?
So the short answer is patients come to see me the last many years, specifically because I offer this procedure. And so I generally take all comers. Patients have kind of self-selected. That's why they're coming to see me. There's a large digital footprint about the procedure online. Having said that, I am very straightforward with the patients, and particularly male patients, especially larger males, in terms of the utility and success rate and very low complication rate performing a lateral sphincterotomy in men. Women in particular, women with functional compromise, patients with previous anal surgery and so forth is a different story. So the majority of the patients I see are women, but there's a considerable number of men as well who have simply decided that they want to try to avoid a sphincterotomy. I don't want to say at all costs, but if there's a reasonable option. The procedure works well. It doesn't work as well in anterior-based fissures. It works particularly well for patients with hypotonic sphincters. So it's interesting how little there is written in our relevant literature about this exact issue of we're typically talking about patients with chronic anal fissures that have hypertonicity. And while that's true for the majority of patients, there's clearly, at least in my practice, many patients who have either normal or quite decreased tone. And the idea of offering these patients a sphincterotomy, I think, is a recipe for disaster. I think it likely explains, to a degree, the functional compromise that we see in some of the literature from sphincterotomy. So in that situation, to me, I think it's a no-brainer to offer patients an alternative to a muscle cutting operation.
I think that is a fantastic point. I haven't, obviously, being aware of low pressure fissures, but I haven't thought about that as an approach. All I sort of learned was you shouldn't do any cutting procedure. So this would certainly be something that I would take on potentially next time I'm faced with such a patient. Are there any specific risks with this procedure? Is there any downside at all?
I think, sure. I mean, the risks are the risks of an anal procedure. So in particular, I talk about risks of infection, specifically abscess. We had one severe infection in a gentleman without insurance who had come from about 250 miles away. And within a few days, I was in touch with him. He had a fever, a high fever. He was clearly getting worse. My concern was that he was abscessing, but he delayed presentation due to monetary concerns at his mother institution until such point that he had not catastrophic, but a severe infection. I am convinced that had he approached an emergency room before that, that could have been avoided. outside of that, we've had a handful of very superficial, simple abscesses directly on the fissure bed. Since I had a rash of those early on, I think there were 3 in a short period of time. In particular, I adopted a less is more attitude about the cauterization part of the procedure. I got into a habit of literally painting the fissure bed with cauterization and getting a nice char. I think that was overkill, and I think it set patients up for abscessing. Since I modified the approach, and now I really just cauterize the superficial aspect, and mainly to achieve hemostasis, as opposed to actually cauterize the hell out of it. Knock on wood, we've had no abscesses since then. There's clearly a risk of functional compromise. I'll tell patients we haven't had any patients with ongoing functional compromise. It doesn't mean the chance is 0, but it's probably very close to 0. We followed what I call a modified fecal incontinence severity index for the first 100 patients, and we noticed no patient had any worsening FISI scores, modified FISI scores in that first 100 patients. We stopped since then following these functional metrics. It was clear that the data was a flat line in terms of preoperative versus postoperative FISI scores. Having said that, we are doing an operation and there's scarring. The consent form talks about a fistulotomy, because again, very frequently we find some degree of burrowing. So I think there's clearly a risk of functional compromise. Patients tend to leak on and off the first several days after the procedure. I suspect this is something really more due to the inflammation and the edema that they have, rather than a muscular injury or an ongoing insult. And then there's failures. The overall success rate, I quote at 85%. That includes all comers, so diabetics, obese patients, smokers, Crohn's patients, irradiated patients. Many of the patients that I see don't have any of those risk factors, and I quote them a higher than 85% chance, but it's not a 95 or 100% success rate. The patients who don't hit a home run in terms of becoming asymptomatic within 6 weeks, generally they become so much better than they were that they don't seek further care. So they may have a residual wound or a festering, but it's not enough to interfere with their quality of life. And so those are kind of the general numbers that I quote patients who are looking at that as an option.
That's very interesting. I guess to end on a future note, where do you see the Kenalog procedure in 10 years' time?
You know, my wife tells me I'm never going to retire, so I imagine we'll still be doing it at Rutgers University. But I don't know. You know, we've made remarkably little progress in fissure care over the years, and I think that there's a growing sense of trying to preserve sphincter as opposed to deliberately cutting sphincter. I've seen in the last 7 years literally double the rate of post-sphincterotomy fissures. I think mainly because surgeons have gotten very concerned, understandably, of cutting too much muscle, and so they're tailoring their sphincterotomy in a various ways to limit how much muscle is trespassed, and this is leading to inadequate sphincterotomy and persistence or recurrence of fissures. And so this just dovetails into the idea that patients are educated and they're looking for alternatives, and they want to have a muscle-sparing approach to fissure therapy. There's a product, it's not on the market yet, but it's in currently a phase 2 trial, which is off-the-shelf calcium channel cream for fissure therapy. It's ultimately going to compete with the existing nitroglycerin product that's on the market. And I'm curious how that's going to, once that becomes widely available, I think it'll supplant the nitroglycerin cream, and we'll see where it goes. Whether or not that's going to eat into Kenalog procedures or sphincterotomies, I don't know, but that's the next, I think, major advance is going to be off-the-shelf calcium channel blocker.
Interesting. Certainly, a lot of people will be welcomed by not having the headaches. So thank you very much. I personally have learned a lot. It's unique to have someone who has thought outside the square to develop a unique approach to a condition. So thank you for giving us the time, and thanks very much to everyone who was on the call. Our next meeting will be in a month's time. We're going to Texas in Baylor University Medical Center. So I look forward to seeing people there.
Thanks very much, Vlad. Really appreciate the opportunity.
Thank you.
Take care.